Class, today we're going to be learning about idioventricular rhythms. An idioventricular rhythm is a backup system of the ventricles. This is when the SA node has failed to fire for some reason and the junction didn't kick in either. We've always said that whatever is the fastest rate is what's going to pace the heart. Normally that should be the SA node. But if the SA node has been injured for some reason, we're hoping that the junction, the AV junction, would kick in at a rate of 40 to 60 as a backup system. But let's say something has wiped out that entire right atrium and it's destroyed the sinus node as well as the AV junction area. We also have automaticity down in our ventricles on the Purkinje fibers of the ventricles. Now, this is the last part of the conduction system, so it's not considered the most reliable. It can be somewhat irregular and unreliable, but it is a backup system for you, and it is definitely better than nothing. So if the ventricles are pacing the heart, it is not because they're irritated. Idioventricular rhythm is strictly because the higher centers have failed. Our rates for idioventricular, some books will tell you 15 to 40, some will tell you 20 to 40, but it's very slow. Since the rhythm originates from the ventricles, the QRS is going to be wide and bizarre, and there's going to be no P wave in front of it since the atrial pacemaker sites have failed. We've already mentioned that it is a regular, R to R is usually a regular rhythm in idioventricular, but again, it is the last fail-safe mechanism of the heart, so it may start becoming irregular. If the rate slows down to where you just have an intermittent QRS complex, the rhythm is considered an agonal rhythm and it represents a dying heart. It is frequently abbreviated IVR for idioventricular rhythm, but you will sometimes hear it called ventricular escape. That is not the most correct terminology for it, but it is something in practice you may hear. But idioventricular is the most common term that we would use for this. Okay, so now if we can get to our next slide here. And I'm sorry, I'm not sure why I can't quite get to it. There it goes. So the other thing you're going to notice in this strip here, this top strip with idioventricular, again, this is a regular rhythm. QRS to QRS to QRS looks regular. I have markings for 6 seconds, so we would count. Technically, that would only be a rate of 30 because that last QRS here, this last QRS here does not actually, the entire QRS does not fall in that 6-second marking. So it would actually be a rate of 30. There's no P wave in front of it, and I notice I have a wide bizarre QRS. It's definitely greater than 0.12. Now, normally your ST segment and T wave changes go in the opposite direction of the QRS. That's not an absolute rule, but it is something we generally see. But with this one, it looks like our ST segment and T wave just looks long and flat. But still, we obviously have a wide and bizarre QRS, so this is going to make this ventricular in origin. So this top one here would be an idioventricular rhythm at 30. Now this bottom strip here, again, QRS to QRS to QRS is regular. Looks like my rate is 30 again. And again, I have no P wave in front of this. My QRS is definitely wide. Oh, I'm sorry, let me go back to that. My QRS is wide, it's greater than 0.12, and I have secondary ST and T wave changes, which is a hallmark of ventricular rhythm. So this would be an idioventricular at 30. Now on this top strip here, QRS to QRS to QRS to QRS is regular. If this is a 6-second strip, my rate would be 40. Again, I have no P wave. My QRS is wide and is exactly where you measure it. I mean, here's where my QRS starts to go up. It looks like it notches or changes directions right there. So it looks like you're about 1, 2, 3, a little over 3 boxes. You can see that my ST segment and T wave go in the opposite direction than the biggest bulk of the QRS. Again, that's not an absolute rule, but it's generally what you will see. And so it has a slow, wide, and bizarre appearance to it. So this would be idioventricular at 40. Now, the way I know this is not a sinus Brady at 40 with the bundle branch block is I don't have a sinus P wave. And it's not an AFib it would not be an AFib with a bundle branch block because R to R is regular. So when you start looking at what we've had, the only thing that this really leaves is idioventricular. Now, the one thing that this can get confused with is maybe a junctional rhythm with a bundle branch block. So if you had a bundle branch block before with your rhythm and now you had this, you might be kind of confused between a junctional rhythm with the bundle branch block versus an idioventricular. But generally, treatment's going to be the same. It's still going to be a slow bradycardia, and we're going to do our treatment the same for that. This bottom strip here, another example here, I have a regular R to R to R to R. My rate is 40. I have no P wave in front of this. My QRS is wide. My T wave goes in the opposite direction, so it looks ventricular in origin. And again, this would be an idioventricular at 40. Now here's only a 3-second strip, but again, it looks regular with only 2 beats to it. No QRS in front of it. I'm sorry, no P wave in front of it, wide QRS, ST segment T wave that goes in the opposite direction, so an idioventricular at 40. So generally the causes of this is because the higher pacing centers have failed. Heart attack is common with it. Significance, we have a reduced cardiac output. We have loss of atrial kick, because remember this is depolarizing from the bottom. Anytime we have a ventricular beat, it depolarizes from the bottom and it travels in a retrograde fashion through the heart. So the atrium ventricles are no longer working in sync with each other. So we've lost our atrial kick, and our ventricular contractions are not as forceful, so they don't push out as much volume, and we have a slow rate in addition to this. So it can kind of set you up for failure here, or patient for failure. So symptoms when we have a drop in cardiac output: altered level of consciousness, dizziness, shortness of breath, chest pain, drop in blood pressure. Our treatment would be to speed this up. You never use suppressive drugs. You don't want to look at this and say, okay, I have a wide QRS, I have something ventricular, I need to give an antiarrhythmic. I mean, when we were talking about VTAC, VFib, PVCs, we were talking about treating them with antiarrhythmics to suppress that ventricular activity. This is all we have left of the heart. If we suppress this, if we gave an antiarrhythmic and suppress these ventricular beats, we would have a flat line at that point and we'd be in asystole. So we never use suppressive medications with this. We are going to treat it as a bradycardia. We're going to give atropine, 0.5 milligrams IV push. We're going to consider that external pacemaker that we've talked about, where we put the external pacemaker on. You turn the rate usually to 60 to 70. You start turning your milliamps or your current up until you actually see the pacemaker spike and capture happen. So external pacemakers work well. A dopamine drip would work well for this as well, but just never given it suppressive medication for this one. And I believe that will end our segment on idioventricular.